So you have to give a good cricoid pressure. Why are we giving the cricoid pressure? Not to see the vocal cords, right? So sometimes we are giving cricoid pressure to see the vocal cords, not like that. We are giving the cricoid pressure so that the gastric content won't come up, right? So we are compressing the esophagus through this cricoid pressure. We are constricting the esophagus so that gastric contents will not come up, because this is a rapid intubation in an emergency we are doing. So we don't want the child to get aspirated. That is why we are giving the cricoid pressure. Then rapid acting muscle relaxant. So suxamethonium is the one we are using. So we are giving the suxamethonium to use the muscle relaxant and intubation of the trachea, and then release of the cricoid pressure. So all these are for emergency intubation, right? So this is an emergency intubation, rapid sequence intubation. So this is what has to be done, and but this is not a good thing, right? So if you have to be in this situation, it is a really bad situation that we have to intubate like this. But if we are able to electively intubate, that is a better thing. If you have to electively intubate, if the child is kept fasting and the anesthetist comes and we give a muscle relaxant, this sedation and everything, and atropine and all those things, and electively intubate, that is a better thing. So most of the time we like to do elective intubation. So that is why we monitor the child, and early intubation is better than going for a rapid sequence induction, right? So in the rapid sequence induction, so you have to know the what are the role of each person. So administering 100%. If there's a CPAP support, we can give the CPAP support. If there's a airway difficulty, we have to get the ENT team and the anesthesia team when we are intubating, right? So ENT team and anesthesia team, if they are there, that will be very helpful. So still the child is having stridor. So facial burns, facial trauma, burns, C-spine injury. So why C-spine injury is difficult intubation? We can't move the neck, no? So we can't move the neck. So there's something called manual inline stabilization, right? Manual inline stabilization. We have to intubate. One person has to hold the head and neck in position, and another person have to intubate. So that's a difficult intubation. And previous difficult intubation. So now we know this child had difficult intubation, so we'll anticipate difficult intubation. Syndromes with facial deformity. So that is a very, very difficult situation, like Pierre-Robin sequence, cleft palate, all those things are very difficult to intubate, right? So even anesthesia, expert anesthetists find it difficult to intubate these children. So you have to allocate the role. So intubator, assistant 1 with equipment and external laryngeal manipulation, and assistant 2 with the drugs, assistant 3 for C-spine manual inline stabilization if required, right? And team has to work together, and all of them should know what to do, right? So assistant 1, correct size face mask. So when managing the oxygenation, you have to use the correct size face mask. Central inflating bag or anesthetic circuit. What is the advantage of anesthetic circuit over the ambu bag? Anybody knows what is the advantage of anesthesia circuit? You all know anesthesia circuit, no? There's a tube and there's a bag which is very floppy with the opening at the end, the green color bag, right? That is not like ambu bag. Okay, so there's a small green bag, no, at the end of the tube. So what is the advantage of using the anesthesia circuit rather than the ambu bag? Ruben? Huh? not rebreathing. Actually, rebreathing, ambu bag, you have an oxygen reservoir. No? So here, the actual the reason is you can deliver a PWP, positive end airway pressure, in the anesthesia circuit, right? Ambu bag, when you inflate and release, comes to zero. The PEEP comes to zero, right? But in the anesthesia circuit, you can you put the anesthesia that bag in between these fingers, no? So they hold, and the tip comes like this, right? They hold it like this, right? And that way you can give a little bit of pressure, so just release the oxygen a little bit, and they ambu with the, so that is giving the PEEP, a positive end expiratory pressure, right? Someone's, yeah, have regulator. I haven't seen that, but the normal ones you have control with the hand, right? So that's a special training you have to do for that, right? So that is a special training. um, um, so that is the advantage. So correct side, Gedel airway, working suction and yanker. Yanker has to be correct size for the pediatric disease. So last time in the intubation, the anesthesia people were asking for a bigger suction tube. So we didn't have it in the NICU, right? And calibrate the capnograph. If you have a ETCO2, this thing, you have to calibrate it. Choice of the working laryngoscope, bougie and stillet, right? Sometimes you put a bougie into the ET tube and stillet. Correct ET tube sizes, neighboring sizes. Check cuff for leak if applicable. If there's a ET tube has a cuff, you have to check that. Stethoscope, ET tube tapes. So this is a work of the one assistant, right? So you have to, there's a checklist. Then the intubator assess an open airway plus or minus adjunct, optimize the head position, administer 100% oxygen via face mask, commence bag and mask ventilation if necessary, ensure full monitoring attached and working. So ECG, saturation, non-invasive blood pressure, everything is fitted and working. Insert NG tube and OG tube to empty the stomach and aspirate continuously. So if you are intubating, you can put an NG tube, and then you can decompress the stomach. Don't worry that that will leak air, right? So some people worry when you put an NG tube, how are you going to do bag and mask ventilation? So it won't happen if you tightly hold that. You can keep the NG tube, right? So that will help in decompressing the stomach. Otherwise, when you bag and mask, the stomach will get distended all the time, right? If the lungs are stiff. Ensure working IV access. So make sure the IV cannula is working. So the second assistant is for the drugs, right? And ketamine dose, recurrenium, we use atracurium, adrenaline for resuscitation in case. Dilute, you know how to dilute the adrenaline, 1 vial in 9 cc of normal saline, and you get 10 cc of 1 in 10,000 adrenaline, right? Right. So sedation, you can use morphine, midazolam infusion, right? Most of these drugs are about 0.1 milligram per kilogram, right? Doses, right? Morphine is 0.1 milligram per kilogram, midazolam is 0.1 milligram per kilogram. So these are the other doses, right? So these are the 3 people who are needed for the intubation. If the manual inline stabilization is needed, you need a 4th person also, right? And we know the sizes. Neonates, we know 3 kilogram, we use 3 or 3.5. So between neonate and 1 year, you have to go between 3 and 4. So you have to have 3 tubes, either 3.5, 4 or 4.5, right? So those are the tubes between newborn and 1 year of age, right? Okay, so depending on the size of the child, right? So when you are intubating, pre-intubation checks. So you know, battery, suction, correct size CT tube, anesthetized and paralyzed. Then we go for the procedure. So I always tell about the whatever procedure you are doing, whatever the procedure, even catheterization, cannulation, whatever the procedure you are doing, preparation is more important than doing the procedure, right? So we always tend to think the procedure is the more important thing, right? But if you prepare everything, then the procedure is easy, right? So if you prepare everything beforehand, the procedure is easy. So always prepare well. So precision and roll or ring. So if you want to keep a head ring, or if you want babies, you want to keep a shoulder thing roll. So the laryngoscopy, right? Now we come to the procedure. So we said there are two types of blades, curved blade and a straight blade. So depending on the blade, we decide where the tip of the laryngoscope blade goes, right? So you all know about the vallicula, no? Vallicula. What is vallicula? Anybody? Ruben? Vallicula is? Huh? Asra, tell. Vallicula is? Where's the vallicula? Correct. I know you all know that. You just no, I'm not telling. Huh? Yes, very good. So above the epiglottis, base of the tongue, right? So your tongue goes like this, right? And then the epiglottis is like this, no? Right, like this, right? So this, imagine this is the tongue, right? My hand is the tongue, and this is the epiglottis. So between the tongue and the epiglottis, right? So that is the vallicula, right? Between the tongue base and the epiglottis is the vallicula, right? So after the tongue finishes, your epiglottis starts, right? So that area is the vallicula, right? So the curved blade, what it does is, it actually goes into that vallicula and pushes the tongue upwards, right? Pushes the tongue forward, so upwards, and then you can the epiglottis comes behind you when you take the tongue up. So you take the tongue up, then the epiglottis, which is like this, it comes up, right? It moves up. So we are putting the blade here and pushing the tongue up, and then epiglottis, which is closing the vocal cords, it will come like this, and you will see the vocal cords, right? But when you are using the straight blade in infants, you are going to the epiglottis itself, right? You are going to the epiglottis and pushing the epiglottis upwards, right? So that is the difference, right? So you take the epiglottis also upwards, and then you can see the vocal cords, right? So bigger children, you use curved blade, vallicula, and push the tongue forward, and smaller babies, we use straight blade, and it go behind the epiglottis and take the epiglottis and tongue together forward. Okay.